Welcome to Deep Dive Ortho, the show dedicated to untangling those intricate musculoskeletal conditions that truly test our diagnostic mettle. You know the ones I mean. That patient whose persistent forearm pain just doesn't quite fit the classic tennis elbow presentation, or perhaps it seems to mimic something else entirely, leaving you scratching your head after the standard investigations come back infuriatingly normal.
Hmm.
We've all encountered these clinical conundrums, cases that demand we move beyond textbook definitions and truly lean into our refined clinical acumen. Today, we're plunging headfirst into one such labyrinthine condition, radial tunnel syndrome.
Ah, yes.
It's often labeled a true diagnostic and treatment dilemma, and for good reason. But why? Okay, let's unpack this.
It's an excellent point. Radial tunnel syndrome, or RTS, certainly presents a significant challenge, even for the most experienced orthopedic professional. What's truly fascinating here is how subtly it can manifest, often masquerading as other, more familiar diagnoses. This mimicry, this elusive nature, demands a truly meticulous and nuanced approach from us.
Yeah.
It's not just difficult, it's deceptively difficult, constantly challenging our assumptions.
So to set the stage for our listeners, who are precisely the mid-senior medical professionals grappling with these very cases, could you give us that foundational definition of radial tunnel syndrome? And crucially, from the outset, how do we distinguish it from those more overt nerve entrapments we're all so familiar with? Because that's often the first diagnostic trap, isn't it?
Absolutely. At its core, radial tunnel syndrome is a compressive neuropathy, specifically affecting the posterior interosseous nerve, which we'll often refer to as the PINE, as it navigates the radial tunnel in the proximal forearm.
Okay.
Now, here's the core diagnostic pitfall for RTS, and it's absolutely crucial for our audience to ingrain this. The hallmark of RTS is almost exclusively pain.
Just pain.
Just pain. This isn't just a symptom, it's the defining characteristic that throws off so many clinicians. You typically won't see the overt motor or sensory deficits like numbness, tingling, or obvious muscle weakness that are the defining signs in other, more straightforward neuropathies, such as carpal tunnel syndrome, or even a full-blown pinned-in palsy.
I see. So the lack of those classic neurological signs is actually a key feature here.
Precisely. This absence of clear motor or sensory changes is exactly what makes RTS such an elusive diagnosis and, frankly, a source of considerable frustration for both patients and clinicians alike. It forces you to look beyond your usual diagnostic algorithms.
And what about prevalence? Is this something we should expect to see often?
Well, when we consider its prevalence, RTS is comparatively rare. We're talking about an estimated annual incidence of approximately 3 cases per 100,000 people.
3 per 100,000. That's
Yeah.
really not very common at all.
No, it isn't. It's a stark contrast to conditions like carpal tunnel syndrome, which has a much higher annual incidence, ranging from 0.1% to 0.35% in the general population. So it's not a condition you encounter daily, which inherently contributes to diagnostic delays simply because it's not always top of mind.
Right, it's not front and center like tennis elbow or carpal tunnel.
Exactly. For our listeners in orthopedic clinics, this means you might see a handful of these cases in your career, but each one can consume a disproportionate amount of diagnostic time.
And the demographics, does it affect certain groups more?
In terms of demographics, RTS appears to be more prevalent in women, typically between 30 and 50 years of age, and it frequently affects the dominant limb.
Dominant limb, okay.
It's also noteworthy that bilateral involvement is uncommon. Studies report it as a rare occurrence, with one particular study identifying only one bilateral case out of 26 patients.
So mostly unilateral. Any other historical points? Previous surgeries, perhaps?
That's an interesting observation, actually. A history of previous surgical procedures on the ipsilateral upper extremity for seemingly unrelated pathologies, such as shoulder instability, trigger finger, or even carpal tunnel syndrome, is a relatively common finding in RTS patients.
Really? That is interesting. Does that suggest some kind of predisposition?
Well, it certainly sparks a discussion about potential predisposition or compounding factors, perhaps altered biomechanics post-surgery, or even a systemic inflammatory response playing a role. We don't know for sure.
And occupation, does that play a part?
It seems so. Occupations involving repetitive heavy manual labor, particularly tasks requiring effort-intensive forearm extensions in pronation or supination, have been proposed as significant risk factors, especially in factory workers. This points towards an occupational component that we as clinicians need to be acutely aware of during the patient history.
Makes sense. And you mentioned the understanding has evolved.
Yes, the very understanding and nomenclature of RTS have, frankly, undergone quite an evolution over the years, mirroring the diagnostic challenges it continues to present.
Yeah.
We can trace its conceptual roots back to 1954, when Michel and Kruger first described a condition we now recognize as RTS, but they termed it radial pronator syndrome.
Right.
Then in 1972, Rolls and Maudsley made a significant contribution. They astutely identified an association between pain and peen compression, and they referred to it as resistant tennis elbow with a nerve entrapment.
Resistant tennis elbow. That really sums up the diagnostic confusion, doesn't it?
It absolutely does. They often treated these patients with surgical decompression of the nerve. That specific terminology really highlighted how difficult it was even then to differentiate RTS from the ubiquitous lateral epicondylitis, a struggle that, as we know, persists to this day in our clinics.
And the term radial tunnel syndrome.
That came later. Moving forward to 1993, Eversman formally adopted the term radial tunnel syndrome, specifically to describe the effect of nerve compression by the supinator brevis muscle. Subsequent articles then broadened this nomenclature to encompass the wider spectrum of physiological symptoms arising from radial nerve compression within the radial tunnel at the elbow, attributing it to various sources like fascial bands, recurrent radial vessels, or the supinator's inferior edge.
Okay, so a gradual refinement of the concept. What about specific signs? I remember Lister and the middle finger extension test.
Ah yes, Lister and colleagues in 1979 famously identified pain with resisted middle finger extension as a potentially pathognomonic sign for RTS. However, as our clinical and anatomical understanding has deepened, later studies have, somewhat frustratingly, found this particular sign to be less consistent or universally reliable.
So not the silver bullet sign we might have hoped for.
Unfortunately not. It underscores the ongoing challenges in nailing down a single, definitive clinical test for this condition. This historical journey serves as a powerful reminder of how continuously we, as orthopedic professionals, must refine our understanding, never settling for a single symptom or sign when dealing with such complex, evolving diagnoses.
That historical narrative truly illustrates why this condition has baffled clinicians for so long. It's a great setup for our next critical piece of the puzzle. You've mentioned the radial tunnel and the PIN. Now, this next part, the anatomy, is where the rubber truly meets the road for us as orthopedic surgeons. Could you guide us through the precise anatomical roadmap of the radial nerve and, crucially, identify those specific, often subtle points where compression is most likely to occur? Because if we don't understand these specific pinch points, we're really just guessing in the clinic.
Precisely. A thorough and intimate grasp of the regional anatomy is paramount for both accurate diagnosis and effective surgical intervention in RPS. The radial nerve itself originates from the posterior cord of the brachial plexus, carrying nerve fibers all the way from the C5 to T1 spinal nerves.
C5 to T1.
It then descends, traveling posterolaterally to the humerus in the radial groove. This long, winding path makes it inherently susceptible to compression and entrapment not just distally, but potentially higher up, which is a consideration we always hold in the back of our minds.
Right, proximal issues need consideration too.
Definitely. Just distal to the elbow joint, a crucial bifurcation occurs. The radial nerve elegantly splits into two main branches. First, you have the superficial radial nerve, which is primarily sensory, providing cutaneous sensation to the back of the arm, forearm, and parts of the hand.
The sensory branch.
And then there's the deep branch, the posterior interosseous nerve, or PNN. This branch is largely composed of motor fibers, responsible for innervating the muscles that extend the wrist and fingers. But here's the critical point, the one that unlocks the RTS paradox. It also carries a significant number of pain-sensing fibers.
Ah, okay. So it's not just motor, despite the name suggesting interosseous.
Exactly. Now let's zoom in on the radial tunnel itself. This is a crucial anatomical concept, essentially a fibro-osseous tunnel. It's approximately 5 centimeters in length, extending from the level of the radiocapitellar joint distally, passing beyond the proximal edge of the supinator muscle.
5 centimeters. Quite a defined space then. What are its boundaries?
Its boundaries are quite specific, creating a tight space for the nerve. Laterally, it's defined by the brachioradialis, the extensor carpi radialis longus, ECRL, and the extensor carpi radialis brevis, ECRB. Medially, you have the biceps tendon and the brachialis muscle. The floor of this tunnel is formed by the stout capsule of the radiocapitellar joint, so you can immediately visualize how constrained this passage can be, leaving little room for error or swelling.
Absolutely, a tight spot. And within this tunnel, where does the compression actually happen?
Well, within this relatively confined tunnel, there are typically 5 distinct sites where the radial nerve, and particularly the PIN, can become compressed, moving from proximal to distal. Understanding these is key. When you're in clinic, performing your physical exam, these 5 points are your targets of suspicion.
Right.
Forget the broad sweep. Precision here is paramount. Each of these sites, even the most subtle fibrous band, can be the singular cause of that patient's debilitating pain. It's about knowing where to lean in.
Okay, let's go through them. Number 1.
Firstly, we have fibrous bands anterior to the radiocapitellar joint. These are often subtle, sometimes appearing as discrete fascial thickenings, but they can act like a tight constricting ring around the nerve, and they can be remarkably difficult to detect preoperatively with imaging, making clinical suspicion vital.
Okay, subtle bands. Number 2.
Secondly, just a little further distally, we often encounter the radial recurrent vessels, frequently dubbed the leash of Henry. These are an arcade of anastomosing arterial branches found at the radial neck. While crucial for blood supply, if they're prominent, thickened, or under tension, they can certainly impinge upon the nerve, especially with dynamic movements.
The leash of Henry. Right. Number 3.
The third potential compression point is the medial edge of the extensor carpi radialis brevis, ECRB. This fibrous edge of the ECRB muscle can create a sharp, knife-like pinch point for the nerve as it passes by. It's another subtle but significant anatomical culprit.
Okay, edge of ECRB. Number 4 must be.
Moving distally, we arrive at what is almost universally considered the most frequent and clinically significant site of entrapment for the peon, the arcade of Fos.
The arcade of Fos, the main suspect usually.
Absolutely. This is a fibrous structure, an aponeurotic or tendinous arch, located at the proximal edge of the supinator muscle. What's particularly relevant here is that anatomical studies indicate a substantial proportion of the population, anywhere from 30% to a staggering 80% of individuals, may exhibit some degree of compression at this specific site, even asymptomatically.
Wow, 80%. So lots of people have the anatomy but don't get symptoms.
Exactly. This inherent anatomical predisposition makes it the prime suspect in many RTS cases. Furthermore, its clinical relevance is starkly highlighted by studies demonstrating that passive pronation with wrist flexion can dramatically increase pressure within this tunnel. Normally, the baseline pressure might be around 50 mmHg, but with this maneuver, it can surge to as high as 250 mmHg.
250, that's a huge jump. Explains why certain movements trigger the pain.
Precisely. This dynamic compression directly correlates with the exacerbation of the patient's pain and is a critical diagnostic clue in your clinical assessment.
Okay. And the 5th site.
And finally, the 5th site within the tunnel is the distal edge of the superficial layer of the supinator muscle. This marks the final potential point of constriction before the nerve exits the main part of the radial tunnel. A complete surgical release must ensure this area is thoroughly decompressed.
Right, need to check right to the end of the muscle. So, you mentioned the PM carries pain fibers despite being mostly motor. Can you elaborate on that? It seems key to the whole pain-only presentation.
Yes, it's a crucial nuance regarding the PN's innervation, the physiological basis for the pain-only conundrum. While it notably provides no cutaneous sensation, meaning patients won't report typical nerve-related numbness or tingling on the skin surface.
Which is what we usually look for.
Exactly. But it does provide robust motor innervation to a wide array of muscles. This includes the common extensors like ECRB, though sometimes the radial nerve proper supplies it, the extensor digitorum communis, extensor digiti minimi, and extensor carpi ulnaris. It also innervates the deep extensors: supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis proprius.
Okay, a lot of muscles.
But here's the physiological clincher that explains our diagnostic challenge. Despite primarily being a motor nerve, the inion also carries unmyelinated group Thori afferent fibers, which are responsible for nociception, that's pain sensation.
Group 4, the pain fibers.
Correct. And it also carries small myelinated group IA afferent fibers, which are associated with temperature sensation. It is the compression or irritation of these specific pain-carrying, unmyelinated and small myelinated fibers that accounts for the deep aching pain experienced by patients.
And these aren't picked up well by standard nerve tests.
Critically, no. Standard electrodiagnostic tests, which primarily assess larger myelinated motor fibers, simply cannot effectively evaluate these smaller fibers. This is why standard EMG and nerve conduction studies return entirely normal results, leading us down a potential blind alley if we're not acutely aware of this neurophysiological reality.
Got it. It's the physiological basis for the pain-only presentation that we discussed earlier, making it a true diagnostic challenge. That detailed anatomical breakdown, particularly your emphasis on the function of those specific pain-sensing nerve fibers, truly clarifies why RTS is so challenging to pinpoint with traditional diagnostic tools. It's almost as if we're looking for the wrong kind of signal. Given this, when a patient walks into your clinic, what are the subtle cues, the red flags that make you think, aha, this could be RTS, even before you start your provocative tests? How do we recognize it amidst the cacophony of other forearm and elbow pains that we frequently encounter?
This is indeed where our clinical acumen truly comes into its own, as RTS is, almost by necessity, primarily a clinical diagnosis, built on history and examination. The primary symptom, as we've reiterated, is a deep, often insidious aching pain.
Deep and aching, not sharp.
Usually deep and aching, yes. The pain is typically localized to the dorsoradial aspect of the proximal forearm, radiating perhaps from the lateral elbow down towards the wrist. Patients often volunteer that the pain significantly worsens with activities that involve repetitive forearm rotation, think pronation and supination, like turning a doorknob or using a screwdriver.
Okay, rotational activities.
And also with lifting activities, especially those that involve a sustained grip or wrist extension. A common complaint, particularly for our professional patients, is that the pain can be particularly aggravated at night, often interfering with sleep, which is a classic symptom in many chronic nerve compression syndromes.
Night pain is a big clue then. What about weakness? Do they feel weak?
Now, it's crucial to distinguish perceived weakness from true motor deficit. While patients might perceive muscle weakness, reporting that their arm feels weak or they can't grip properly, this is nearly always secondary to the pain itself.
Ah, so it's pain inhibition, not actual nerve damage causing weakness.
Exactly. The sheer discomfort makes it difficult or impossible for them to generate full, uninhibited force, rather than indicating actual denervation or structural damage to the motor nerve fibers. This is a very important distinction, as true objective motor weakness, especially specific digital or thumb extensor weakness, would immediately point you more towards a posterior interosseous nerve syndrome, which is a different beast entirely.
Right. PN syndrome has definite weakness. RTS has pain causing apparent weakness. Got it. What about the physical exam? Where do you press?
On physical examination, the most crucial finding, the diagnostic gold, is the presence of maximal tenderness. This is typically located 3 to 5 centimeters distal to the lateral epicondyle, usually over the mobile wad of Henry, specifically over the supinator arch.
3 to 5 centimeters distal. That's very specific.
It is. This is a precise point, and it's absolutely vital to differentiate it from the direct tenderness over the lateral epicondyle, which is the hallmark of lateral epicondylitis or tennis elbow. That difference of a few centimeters is your primary physical diagnostic clue.
So if the main tenderness is right on the bone, think tennis elbow. If it's further down over the muscle, think RTS.
Precisely. If you find yourself directly pressing on the epicondyle and eliciting maximal pain, you're likely dealing with epicondylitis. But if the pain is reproducibly 3 to 5 centimeter distal over the supinator, your radar should immediately ping for RTS.
Okay. What about tests to provoke the pain?
To further elicit and confirm the pain, we rely on several provocative tests, each designed to stress the radial nerve within its tight tunnel. Firstly, the resisted long finger extension test. When you ask the patient to extend their middle finger against resistance, it directly engages the deep extensor muscles innervated by the pin. This maneuver reproduces pain specifically at the radial tunnel. Again, it's the pain response that's key, not necessarily weakness.
Okay, resisting middle finger extension. What else?
Secondly, the resisted supination test. This is performed with the elbow and wrist in extension. Asking the patient to supinate their forearm against resistance actively contracts the supinator muscle, thereby tightening the radial tunnel around the nerve. This will also typically reproduce pain at the radial tunnel. Again, any perceived weakness is due to pain, not true motor deficit.
Resisted supination in extension, and the third one.
And thirdly, passive pronation with wrist flexion. This maneuver specifically stretches the supinator muscle. As we discussed earlier, this significantly increases pressure within the radial tunnel from a normal 50 mmHg to potentially 250 mmHg.
Big pressure increase maneuver.
Exactly. This dramatic increase in pressure directly intensifies the patient's pain. So if the patient reports marked pain exacerbation with this passive stretch, it's a strong indicator of dynamic compression within the tunnel.
Makes sense. I've also heard about the Rule of 9 test. How does that fit in?
Yes. Another valuable clinical test, developed by Lowe and colleagues, is the Rule of 9 test. This is designed to provide a more structured approach to evaluating nonspecific elbow and proximal forearm pain, almost like a clinical roadmap.
Okay, a grid system.
Essentially, yes. You subdivide the anterior proximal forearm, just distal to the elbow crease, into a 3 by 3 grid, roughly the size of a half-dollar coin. You then apply firm, consistent pressure to each of these 9 circular regions.
Right.
Tenderness in the 2 proximal circles of the lateral column strongly indicates radial nerve irritation. The posterior interosseous branch of the radial nerve lies more distally, so tenderness in the 3rd discal lateral circle would not typically irritate the radial nerve and can serve as a control, in addition to the 3 medial circles, which are also control areas and expected to be pain-free.
So top 2 lateral squares point to radial nerve. What about the others?
Tenderness in the 2 distal circles of the middle column, conversely, might suggest median nerve irritation. This test provides a systematic, objective way to pinpoint the precise location of tenderness, which can be immensely helpful in differentiating between nerve entrapments.
That sounds very useful for mapping the pain. Now, you mentioned the confusion with tennis elbow earlier. How often do they actually coexist?
Speaking of which, we cannot overlook the significant, often confounding overlap between RTS and lateral epicondylitis. This is a common pitfall that challenges even the most experienced clinicians. RTS can coexist in about 5% of patients already diagnosed with lateral epicondylitis,
5%.
with some studies reporting this figure as high as 21% to 41%.
Wow, up to 40%. That's a huge overlap. Why is that?
Well, there's a compelling theory that in some of these patients, the deep aching pain experienced from a degenerated ECRB tendon in lateral epicondylitis might actually be referred via the pins afferent pain fibers.
Ah, so the nerve is carrying the pain signal from the tendon problem.
Possibly. This explains why the 2 conditions can be so difficult to distinguish, and why treating one, perhaps with an epicondylar injection, may not fully resolve the symptoms if the other is also present. It means we must always consider both and differentiate meticulously, rather than stopping at the most obvious diagnosis.
Right, so it's often a diagnosis of exclusion then. What else needs ruling out?
Ultimately, RTS is very often a diagnosis of exclusion. We need to methodically rule out other conditions that present with similar symptoms, a process that requires a comprehensive differential diagnosis. It's quite a list.
Okay, let's hear it.
Lateral epicondylitis, as just discussed, which is by far the most common mimic, but remember that 3-5 centimeter distal tenderness, cervical radiculopathy, particularly at the C6-7 level. While it can cause radiating pain down the arm, electrodiagnostic studies would typically show denervation patterns in the affected myotomes that are not seen in RTS. You'd also expect neck movements to reproduce symptoms.
Okay, neck issues.
Posterior interosseous nerve, PIN syndrome. This is distinct from RTS because it presents primarily with overt motor signs, such as digital and thumb extensor weakness, including a classic finger drop or wrist drop. Crucially, it typically presents with the absence of pain, which directly contrasts with the pain-dominant picture of RTS.
So if you see objective weakness without significant pain, think PN syndrome. Very clear distinction.
Exactly. Superficial radial nerve irritation, which can mimic conditions like de Quervain's tenosynovitis due to pain over the radial styloid and first dorsal compartment. However, its pain is typically more superficial, sensory in nature, and elicited by direct palpation over the superficial radial nerve itself.
Different location, different quality of pain.
Yes. Proximal nerve pathology, such as brachial plexus inflammation or trauma, which might present as more diffuse shoulder or upper limb pain, often with more widespread neurological deficits. Biceps tendinopathy, causing pain around the anterior elbow, usually at the biceps insertion or in its belly, and exacerbated by resisted elbow flexion and supination.
Different area again.
Osteoarthritis, or synovitis, of the radiocapitellar joint, which would present with joint-specific pain, often mechanical in nature, crepitus, and tenderness directly over the joint line, distinguishable from the nerve tenderness. Muscle tears, such as an ECRB tear, which would typically have more acute onset, a specific mechanism of injury, and localized pain with resisted rest extension.
Acute onset, usually.
And finally, posterior plique impingement, which is a mechanical issue within the elbow joint, often causing clicking, locking, or pain with full extension, not typically the deep aching pain of RTS.
Quite a list to work through. The astute recognition of the clinical presentation, combined with these careful differentiations through a thorough physical examination, truly forms the cornerstone of diagnosing RTS. That comprehensive overview of the clinical presentation and the vast differential diagnosis truly underscores the complexity. It highlights that in a condition like RTS, the clinician's skill in history-taking and meticulous physical examination remains paramount. Yet, despite these clear symptoms, objective confirmation often proves elusive. So what does this all mean for the role of imaging and electrodiagnostic studies? How do we leverage them, or perhaps not leverage them, in this persistent diagnostic dilemma? Because it seems like the standard tools can sometimes misdirect us.
This is precisely where the dilemma lies, and it's a constant source of frustration. For many other neuropathies, electrodiagnostic studies are a gold standard, offering definitive confirmation. But for RTS, they often lead to confusion or, worse, premature dismissal of the diagnosis.
Right, the classic normal EMG scenario.
Exactly. Let's begin with electrodiagnostic studies, meaning electromyography, EMG, and nerve conduction velocity NCV tests. The critical point here, and it bears repeating because it's a fundamental misunderstanding for many, is why these tests are typically normal or inconclusive in patients with radial tunnel syndrome.
Okay, why?
It's fundamentally due to the type of nerve fibers involved in the pain sensation and what these tests are actually designed to measure. The posterior interosseous nerve, as we discussed, carries unmyelinated group 4 fibers, often referred to as C fibers, which are responsible for nociception, or pain,
The slow pain fibers.
and also small myelinated group IIA afferent fibers, which transmit temperature sensation. When these specific small diameter fibers are compressed or irritated, they produce the deep, aching pain the patient experiences. However, standard EMG and NCV tests are designed to evaluate the function of larger, well-myelinated motor fibers.
So the fast-conducting ones?
Correct. Since these larger motor fibers of the PI generally remain unaffected in RTS, the standard electrodiagnostic tests will typically show normal conduction velocities and normal muscle activity, leading to what many clinicians might mistakenly interpret as a negative or normal study.
Which can shut down the investigation prematurely.
It often causes a diagnostic dead end, sending the clinician off on a tangent, when in fact a normal study does not rule out RTS. While some research has attempted to find subtle differential latency abnormalities, perhaps comparing nerve conduction in different forearm positions or looking at specific small fiber responses, these findings are not universally accepted as definitive diagnostic criteria due primarily to technical difficulties, variability, and a lack of consistent reproducibility across centers.
So the bottom line on EMG and CV.
The consensus among experts is clear. A normal EMG NCV does not rule out RTS. It's a test looking for the wrong kind of signal for this particular condition.
Okay, that's a really crucial takeaway. What about imaging? MRI, can that show the compression?
Next, let's consider imaging, specifically MRI. In the vast majority of radial tunnel syndrome cases, an MRI scan of the elbow or forearm will be reported as entirely negative for direct pathology of the nerve itself.
Again, often frustratingly normal.
Exactly. This can be disheartening for both the patient and the clinician seeking an objective correlate to the debilitating pain. However, MRI does retain some utility, albeit often for identifying indirect signs or, more commonly, for ruling out other conditions.
What sort of indirect signs might we see?
For instance, an MRI might occasionally identify subtle indirect signs of chronic nerve compression. These could include denervation edema or, in more chronic cases, even atrophy within the muscles innervated by the pin, such as the supinator or other extensor muscles in the forearm.
Muscle changes, okay.
While these findings are not always present when seen, they can certainly lend support to the diagnosis. MRI can also, in some cases, visualize potential compression sites, a thickened edge of the ECRB, a prominent radial recurrent vessel, the leash of Henry, or even subtle swelling or altered signal intensity of the pin itself.
But these aren't definitive.
No. It's important to acknowledge that the validity and consistency of these MRI findings as definitive for RTS remain quite controversial amongst experts. Many of these findings can be incidental or nonspecific.
So what's its main value then?
Crucially, the primary and most valuable role of MRI in the workup of suspected RTS is often to rule out other causes of entrapment or elbow pain that have more overt structural pathology.
Okay, ruling out the other things on that long differential list.
Precisely. This includes identifying space-occupying lesions like tumors, ganglia, or other specific pathologies such as radiocapitellar synovitis, bicipital bursitis, or even subtle radial head fractures and dislocations. So, while it may not directly confirm RTS in most cases, it's invaluable for narrowing down the differential diagnosis and ensuring you're not missing a more overt structural problem that could be masquerading as nerve pain. It helps you rule out the zebras that look like horses.
Right, essential for excluding other pathology. What about injections? Can they help diagnose?
Finally, we come to the diagnostic injection. This is often the most valuable and often the ultimate arbiter in our diagnostic arsenal for RTS, and it has the added benefit of potentially serving a therapeutic purpose.
Okay, how does that work?
The radial tunnel injection test, involves precisely injecting a local anesthetic into the area of maximal tenderness, that specific spot 3 to 5 centimeters distal to the lateral epicondyle over the supinator arch.
Injecting right where it hurts.
Exactly. A truly diagnostic response occurs if the injection leads to both temporary pain relief and a temporary posterior interosseous nerve palsy.
Ah, the temporary palsy is key, so temporary weakness after the injection.
Yes, the temporary PN palsy is a key finding and would manifest as transient temporary weakness in the digital and thumb extensors. This combination, acute pain relief coupled with a transient motor deficit, strongly implicates the radial nerve within the tunnel as the definitive source of the patient's pain.
That sounds quite definitive if you get that response. Any pitfalls?
Well, it's paramount to perform this injection meticulously, ensuring the anesthetic does not spread to the lateral epicell itself, as inadvertently numbing the common extensor origin could lead to a false positive by relieving pain from a concomitant lateral epicondylitis.
Right, need to be precise with the needle placement.
Absolutely. This careful technique ensures the diagnostic accuracy of the injection. So while other tests may be inconclusive, a well-executed diagnostic injection can often provide that critical piece of the puzzle, confirming your clinical suspicion and guiding treatment. It's often your make-or-break moment.
That's a truly clear roadmap through the diagnostic thicket. It's evident that managing radial tunnel syndrome demands not just a high level of clinical suspicion and precision, but also patience. Once a diagnosis is reached, even if by exclusion and a positive diagnostic injection, what are the recommended pathways for treatment? Can you walk us through the conservative approaches and then, for those truly refractory cases, the surgical considerations? Because, as we've established, there's certainly no single silver bullet here.
You're absolutely right. Precision and patience are paramount. Once a diagnosis of radial tunnel syndrome is made, our primary objectives for treatment are clear: pain resolution, restoring functional independence, and critically, facilitating the patient's safe and sustainable return to their work and daily activities.
Makes sense. So where do we start? Conservative first, presumably.
Always. We generally adopt a stepped approach, starting with a comprehensive course of conservative management. This is typically recommended for a prolonged period, often at least 3 to 6 months, and in some cases up to a year, before considering surgical intervention.
3 months to a year, that's quite a long trial.
It is. This lengthy conservative trial is important given the variable nature of the condition and the potential for spontaneous improvement. You really want to give these non-operative measures a fair shot.
Okay, so what does that involve? What are the components?
Let's detail the components of this initial non-operative management. Firstly, activity modification. This is foundational. We advise patients to meticulously identify and strictly avoid specific activities that consistently aggravate their pain.
Like the rotation and lifting we discussed earlier.
Exactly. This invariably includes prolonged elbow extension with forearm pronation and wrist flexion, as these postures are known to increase pressure within the radial tunnel. Similarly, any repetitive pulling, pushing, or twisting motions that exacerbate symptoms should be avoided or significantly modified. Simple resting of the affected limb from aggravating activities is also a crucial component to allow the irritated nerve to recover and reduce inflammation.
So tailoring advice to their specific activities is key.
Absolutely. For a carpenter, this might mean temporarily avoiding heavy drilling or using specific power tools. For an office worker, it could involve adjusting keyboard and mouse ergonomics to maintain a neutral wrist position.
Makes sense. What about splinting?
Secondly, temporary splinting. The use of wrist splints can be highly beneficial. They serve to immobilize the wrist, typically in slight extension, and limit movements that specifically aggravate the radial nerve. This helps to offload the common extensor origin and reduce tension on the radial nerve.
Just a standard wrist splint.
Yes, often Velcro wrist splints are recommended for their ease of use and adjustability, allowing for comfortable wear throughout the day or during specific activities.
Okay. Medications? Standard anti-inflammatories.
Thirdly, medication. Non-steroidal anti-inflammatory drugs, or NSAIDs, are typically prescribed as a first-line pharmacological intervention. They help manage the pain and reduce any associated inflammation around the nerve. While they don't treat the compression, they can help manage the inflammatory component of the pain.
Right, managing symptoms. And injections again. Therapeutic this time.
Fourthly, corticosteroid injections. As we discussed in the diagnostic phase, these can be both diagnostic and therapeutic. When administered precisely into the radial tunnel, usually targeting the area of maximal tenderness around the supinator, they aim to reduce inflammation and swelling directly around the compressed nerve.
How effective are they for treatment?
Reported outcomes for these injections can be quite encouraging in some patients. For example, some studies cite approximately 70% improvement at 6 weeks post-injection, and remarkably, 60% of patients remaining pain-free at 2 years in certain cohorts.
That sounds pretty good.
It can be. However, it's important to be transparent with patients about the variability. Other studies have reported more modest success rates for non-surgical treatments as a whole, with some indicating only 4 out of 15 patients improving significantly with conservative measures alone.
So results vary quite a bit.
They do. This variability often comes down to the precision of the injection, the exact nature of the underlying compression, and patient selection. One notable study reported that a single injection of lidocaine and triamcinolone achieved 72% pain relief after 6 weeks and maintained 64% relief for over 2 years, underscoring that for some, this can be profoundly effective.
Worth trying then, but manage expectations. What about physio?
Finally, physical therapy. A structured physiotherapy program is an essential long-term component of conservative management. This typically includes targeted exercises designed to improve forearm strength and flexibility, along with specific nerve gliding exercises, often called nerve floss,
Sever gliding, yes.
which aim to improve the mobility of the radial nerve within its tunnel, preventing adhesions and reducing mechanical irritation. Modalities such as therapeutic ultrasound massage or deep tissue release may also be employed to address fascial restrictions.
And occupational therapy, ergonomic.
Absolutely. Furthermore, occupational therapy plays a vital role here, focusing on teaching patients ergonomic techniques and body mechanics to prevent symptom recurrence once they gradually resume their activities. This might involve workstation adjustments, tool modifications, or posture training.
Any newer physio approaches?
Yes, more advanced physical therapy programs are now exploring concepts like motion-specific release, MSR treatment systems, which take a holistic view, addressing not just the local site of pain, but the entire kinetic chain and fascial system that might be contributing to nerve tension. They focus on loading affected structures in a progressive manner to build resilience and improve tissue tolerance.
Interesting. So if all that fails after, say, 6 months to a year?
Despite these comprehensive measures, the success rates for conservative treatments can indeed be variable, as highlighted by the conflicting study outcomes. If, after an extensive and diligent course of non-operative treatment, typically lasting between 3 to 6 months or even up to a year, the symptoms persist, significantly impact the patient's quality of life, and you have confirmed your diagnosis with a positive diagnostic injection, then operative management or surgical release becomes the next logical step.
Okay, surgery. What's the principle?
The fundamental surgical principle behind a radial tunnel release is to meticulously decompress the radial nerve and its branches, specifically the posterior interosseous nerve and often the superficial radial nerve, by releasing all anatomical structures that are compressing it along its course through the radial tunnel. This is about ensuring complete liberation of the nerve.
Getting rid of all those potential pinch points we talked about, what are the common approaches?
There are several surgical approaches commonly employed, each with its own advantages and indications. Dorsal approaches. These are quite common and familiar to most orthopedic surgeons. One involves an incision between the extensor carpi radialis brevis, ECRB, and the extensor digitorum communis, EDC. Another, widely known as the Thompson approach, is executed between the brachioradialis and the extensor carpi radialis longus, ECRL.
Right, standard approaches. Anything to watch out for?
During these approaches, it's absolutely crucial to carefully identify and protect the posterior cutaneous nerve of the forearm to avoid iatrogenic sensory deficits. Blunt dissection is then meticulously used to expose the supinator muscle and the nerve. The primary goal here is to release the arcade of Fros, which is almost always the key compression site, and also the distal edge of the supinator, ensuring the nerve has ample room throughout its passage.
Can you deal with tennis elbow at the same time?
Yes. A common advantage of these approaches is that if a patient also has concomitant lateral epicondylitis, the incision can often be extended proximally to address that pathology as well, making it a single-stage procedure. A transmuscular brachioradialis splitting approach is also described, where the brachioradialis muscle fibers are split longitudinally to reach the radial nerve, potentially reducing the overall incision size but requiring precise muscle splitting technique.
What about an anterior approach?
Anterior approach. This approach involves a curvilinear incision typically made between the brachioradialis and the biceps. It's particularly useful, though less common for isolated RTS, when there's a strong suspicion of more proximal compression of the radial nerve, as it allows for better exposure of the nerve both proximal and distal to the elbow joint. It provides a wider field of view for higher lesions.
Okay. Regardless of approach, what absolutely has to be released?
Regardless of the specific approach chosen, there are consistent key decompression steps that are critical for a successful outcome and must be performed with meticulous care. 1. Releasing the arcade of Fros. This is the absolute priority. Given it's the most frequent and significant site of entrapment, it must be completely transected.
Number one priority.
2. Ligating the radial recurrent blood vessels, the leash of Henry, if they are found to be constricting or creating a tension band around the nerve.
Dealing with the leash if necessary.
3. Releasing the distal edge of the supinator and any other fibrous bands that are superficial to the radiocapitellar joint. It is essential that the entire length of the supinator muscle and its surrounding fascia is visualized and completely released, ensuring there are no remaining points of constriction. The principle is comprehensive decompression.
Okay, a thorough release is essential. Now, the big question. How well does surgery actually work? What are the outcomes?
Now, let's talk about surgical outcomes, as it's important to set realistic expectations for patients, particularly given the variability. Reported success rates for surgical decompression of radial tunnel syndrome vary widely in the literature, typically ranging from 50% to 90% good to excellent results.
50 to 90% is a huge range.
It is. Some of the more optimistic studies have reported complete symptom diminution in 67% to 93% of patients. However, it's equally important to highlight some of the challenges and factors that can lead to lower success rates, as these are the cases that often come back to our clinics with persistent pain.
Such as?
For instance, maximal recovery can be significantly delayed, sometimes taking up to 9 to 18 months, requiring considerable patience from both patient and clinician.
9 to 18 months for full recovery. That's a long time.
It can be. Furthermore, certain patient groups tend to have less favorable outcomes. Those with concomitant multiple entrapment neuropathies, where success rates may drop to around 60%. Patients with coexisting lateral epicondylitis, with success rates reported as low as 40%.
Only 40% if they also have tennis elbow. That's sobering.
Yes, perhaps because the epicondylar pain, even if referred, becomes the dominant lingering issue. And unfortunately, workers' compensation patients who regrettably show the lowest success rates, sometimes as low as 30%.
30%. That's quite a stark difference. Really highlights the psychosocial factors.
It absolutely underscores the profound influence of psychosocial factors, secondary gain, and the medical-legal context on surgical outcomes, which we, as surgeons, must be acutely aware of and address preoperatively. Some studies also advocate for decompression of both the posterior interosseous nerve and the superficial radial nerve rather than just the pinoin for potentially better overall outcomes, especially if there's any suspicion of superficial radial nerve involvement.
Okay, and post-op recovery. What does that involve? Risks.
Postoperatively, patients typically face a recovery period of 3 to 6 months, and physical therapy is often a crucial component to aid rehabilitation, restore strength, improve range of motion, and prevent stiffness or scarring around the nerve. As with any surgical procedure, there are inherent risks, including general anesthesia risks, potential nerve injury, though rare, it can be devastating, persistent pain if the decompression is incomplete or the diagnosis was incorrect, scarring and residual weakness. It's a significant decision that requires careful patient selection and comprehensive preoperative counseling, ensuring the patient fully understands the potential benefits, limitations, and risks. #TAG6, long-term outlook, and the broader picture.
That's a very thorough overview of the treatment spectrum, from those essential conservative measures to the nuances of surgical intervention and their often variable outcomes. It truly underscores that there's no single silver bullet for RTS, and successful management relies on a thoughtful, layered approach. As we wrap up this deep dive, could you discuss the long-term prognosis for these patients and perhaps more broadly, what insights this condition offers us for a more holistic, patient-centered approach to orthopedic care? Because it feels like RTS is a microcosm of chronic pain conditions, doesn't it?
It absolutely is a microcosm. The long-term prognosis for individuals diagnosed with radial tunnel syndrome can, as you've observed, vary quite significantly. This variability hinges on several critical factors, such as the severity and duration of the nerve compression at the time of presentation, and crucially, the timeliness and appropriateness of the intervention.
So catching it early is really important.
Early recognition and prompt initiation of treatment are absolutely vital. Delaying treatment can unfortunately lead to more profound and potentially irreversible changes, such as muscle atrophy or the development of dense, fibrous tissues around the nerve.
Making recovery much harder later on.
Exactly. These changes can significantly diminish the likelihood of a satisfactory recovery, even after meticulous surgical interventions like neurolysis or nerve decompression. While conservative management often yields good results for many patients, it's important to reiterate that surgical outcomes, while promising for a significant proportion, can be variable, with some patients still experiencing persistent symptoms. This highlights that for some, the nerve may have been irritated for too long, leading to irreversible changes, or that there are other factors at play.
So what does good long-term management look like to prevent recurrence?
For optimizing long-term recovery and minimizing the risk of recurrence, long-term management requires a proactive and sustained approach from both the patient and the entire care team. This means consistent adherence to ergonomic adjustments in their work and daily life.
Adapting their environment.
Yes. For a surgeon, this might mean adjusting how they hold instruments during long cases. For a dentist, it's about chair height and patient positioning. It also means diligent compliance with prescribed physiotherapy protocols, which often include ongoing nerve gliding exercises and strengthening programs to maintain muscle balance and nerve mobility. Regular follow-up appointments with their healthcare providers are fundamental to track progress, identify any emerging issues, and adjust management plans as needed.
Continuous engagement, then.
Absolutely. This continuous engagement is fundamental to maintaining function and reducing pain over time. We're not just treating a nerve, we're managing a person's long-term functional capacity.
You mentioned other factors. The psychological side must be huge with this kind of chronic, nagging pain.
Now, one aspect that is frequently overlooked but is profoundly significant in conditions like RTS is the psychological and well-being impact. Patients living with chronic pain, such as that associated with radial tunnel syndrome, often experience substantial psychological distress.
Anxiety, depression.
Exactly. This can manifest as elevated levels of anxiety, depression, and even catastrophizing, which in turn can significantly exacerbate their pain perception, reduce their pain tolerance, and ultimately impair their overall functional capacity.
It becomes a vicious cycle.
It really does. This is not merely a secondary effect. There's a bidirectional relationship where chronic pain can lead to psychological distress, and that distress, in turn, can amplify the pain experience.
Yeah.
It highlights a critical need for a truly holistic approach to treatment that explicitly integrates psychological support alongside the physical treatments we've discussed.
So we need to address the mental health aspect directly.
Absolutely. Addressing these mental health aspects, perhaps through cognitive behavioral therapy for pain, mindfulness, or simply validating your experience, is not merely a supplementary measure. It's essential for comprehensive management and improving the patient's overall quality of life. We've seen how emotional support from family and friends has also been shown to significantly alleviate pain perception, underscoring the broader social context of recovery.
That's a crucial point. As orthopedic surgeons, while our primary focus is biomechanical, we must recognize that ignoring the psychological burden can severely limit the success of even the most technically perfect surgical intervention.
Precisely. This complexity inherently necessitates an interdisciplinary collaboration in the treatment approach. Managing RTS effectively often requires a coordinated effort involving orthopedic surgeons, specialist physiotherapists, pain management specialists, and, as we just highlighted, potentially mental health professionals.
The team approach.
Yes. This collaborative model allows for the development of truly tailored management plans that specifically address the unique symptoms, functional limitations, and lifestyle demands of each individual patient, rather than a rigid, one-size-fits-all approach. For instance, a regular case conference where the surgeon, physio, and pain specialist discuss a particularly challenging RTS patient can lead to insights that none could have achieved in isolation. It also helps navigate the often differing opinions among practitioners on the best course of action by fostering a shared understanding and unified strategy.
Collaboration is key for these complex cases. Are there any recent advancements changing how we manage RTS?
Looking at recent advancements, our understanding and management strategies for RTS continue to evolve, moving towards more refined, patient-specific interventions. There's a growing emphasis on evidence-based practices, integrating meticulous physical examination and special clinical tests with advanced imaging techniques like high-resolution ultrasonography, which is showing promise in visualizing subtle nerve pathology and compression and refined electrophysiological assessments, even if standard EMG-NCV remains challenging for RTS.
Ultrasound is becoming more useful then.
Potentially, yes. In physical therapy, we're seeing innovations like advanced programs that include more challenging exercises aimed at specifically loading the affected structures in the forearm and wrist, building muscle strength and resilience, and integrating neurodynamics more deeply. Concepts like motion-specific release, MSR treatment systems, are gaining traction, offering holistic manual therapy and tailored exercises that consider the entire kinetic chain.
Looking beyond just the elbow.
It's exactly. Releasing myofascial restrictions that might indirectly contribute to nerve irritation and focusing on restoring natural movement patterns. On the surgical front, techniques are continuously being refined, focusing on precise, minimally invasive decompression of the radial nerve to provide more reliable relief and improved functionality, with some surgeons exploring endoscopic approaches for select cases.
Endoscopic release. Interesting.
Beyond specific treatments, there's an increased focus on prevention through ergonomic adaptations and lifestyle modifications. This proactive approach aims not only to mitigate the onset or recurrence of RTS, but also to generally enhance the quality of life for individuals at risk. If we connect this to the bigger picture, RTS serves as a powerful reminder that complex pain conditions demand a multifaceted, integrated approach that looks beyond just the anatomical lesion to encompass the patient's entire experience in their psychosocial context. It pushes us to be better, more holistic clinicians.
That's a truly insightful synthesis. It brings us back to the central theme of this deep dive. Radial tunnel syndrome as a diagnostic and treatment dilemma characterized by its elusive pain-only presentation, the specific anatomical sites of compression that we've so meticulously detailed, and the crucial role of a nuanced, patient-centered clinical examination. It's a stark reminder that even in an era of advanced diagnostics, the art of medicine, especially in orthopedics, remains paramount, demanding a thoughtful, interdisciplinary, and truly holistic approach.
Well said.
If you found this deep dive valuable, please do consider rating and sharing it with your colleagues and peers in the orthopedic community. As we conclude, I'd like to leave you, our listener, with a thought to ponder. In an era of advanced diagnostics, how might we further refine our understanding of nerve pain conditions where subjective experience so profoundly shapes the clinical reality? And what more can we do to support the often invisible psychological burden of chronic pain for our patients, integrating it seamlessly into our practice? Thank you so much for sharing your invaluable expertise with us today.
My pleasure entirely. This raises an important question for all of us to continue exploring and innovating in our practice.
And that concludes this deep dive into radial tunnel syndrome. Until next time.